Now, this is a very interesting ECG where we'll be today saying a very typical feature of an old myocardial infarction, and that is Q wave. So we know that Q wave is the first negative wave. It is the first negative wave after P wave. So whenever we see uh, P wave, always after that, whichever wave which comes the earliest is Q wave. So usually Q wave is only and only seen physiologically. If it is seen, it is only seen in lead 3. So in lead 3 only we can see Q wave, and it is of no any significance. Apart from lead 3, we should not be able to see any Q wave in any other lead. So again, it's just like heart attack or just like STEMI. Any Q wave has to be present in at least more than two consecutive leads. Consecutive leads means we always need to remember that it has to be lead 2, 3, AVF. These are inferior wall leads. Lead V1 to V4, we can call it as anterior leads. Lead 1, AVL, V5, V6, these are called lateral leads. So lead presentation has to be or the presence of Q wave has to be in these consecutive leads. Now, when we see in this ECG, we can very nicely make out that this is lead 1, this is lead 2, this is lead 3, and this is lead AVF. So, notice out, first we'll see here in all the other, these are chest leads. See, this is, yeah, R wave. There is no Q at all. So Q wave is not there at all in lateral leads. So this is R wave. This is R. There is no even a slightest of Q wave is not there. So this is P, and there is no Q wave at all. There is only and only S. It is only in, sorry, not S, it is only and only R and S. So R and S. See in V6 as well, there is only R and S. There is no Q at all. So there is no slightest of Q wave as well. So there is no absolute criteria for a significant Q wave length. If it is not present in most of the leads, and if it is present in two or more than two consecutive leads, in particular leads, then it is a significant Q wave. So we can see in V2, Q is not there at all. It is just a P followed by a positive R and then S. Q is not there at all. Q is not there at all in any leads. And now compare lead 2, 3 AVF. So lead 2 starts with Q wave. So this is Q wave. Q wave is downsloping. So this is Q. So we can very nicely make out Q, R, S. Q, R, S. Q, R, S. So this is the first, this is P wave. So first negative wave after P is Q. So this is all Q. So Q, R, S. So this is Q. So lead in the inferior wall leads persistently. Q wave is present in all the three leads, that is lead 2, lead 3, and lead AVF. So a Q wave present in more than two consecutive leads suggests that there is infarct. There is old infarct. If there is persistent ST elevation, patient presenting with chest pain for few hours, and if you are able to see ST elevation as well as Q wave, you can call that patient has evolved MI. So presence of Q wave only denotes two conditions. Either it is evolved MI. Evolved means the heart attack is of few hour duration, preferably maybe 6 hours, 8 hours duration, or it is an old myocardial infarction. Old, it can be means it can be of months old, years old. So Q wave will be always present. So if you are able to see Q wave, and if patient had chest pain, if patient's drop T, CKMB, these biomarkers come positive, and if patient presents with chest pain, and if patient had some ST elevation as well as Q, then it can be definitely an evolved MI with positive Q wave. But if you simply do an ECG, maybe a routine ECG, and you see such patterns, such presence of Q wave, then it usually denotes old myocardial infarction. In this particular patient was not having any chest pain. Patient had admitted with fever, and on doing a routine ECG, we could find this Q wave abnormality. Patient's EF was around 45%, so it means that patient had old inferior wall MI that led to have this Q wave, very typical in lead 2, 3 and AVF. So we'll again meet in the next very interesting topic. Till then, bye all. Thank you.